Good morning, and welcome to the third and final day of our conference on character and the professions. My name is Michael Lamb, and I'm the Executive Director of the Program for Leadership and Character here at Wake Forest, and Assistant Professor of Interdisciplinary Humanities. On behalf of our program and our wonderful partners at the Oxford Character Project, I'm delighted to welcome you to this morning's session on character and medicine. We have over 2,300 people from 37 countries and 6 continents registered for this conference, so we're grateful you can be with us this morning for our session. The first 2 days have been just terrific, and we know that today's sessions will be as well. We have wonderful sessions planned on character and business at 12 p.m. Eastern Time and character and law at 3 p.m. Eastern Time, so we hope you will join us for those sessions as well later today. For now, I'm pleased to introduce you to our session on character and medicine. It will feature a keynote address from Dr. Margaret Plews-Ogan from the University of Virginia, followed by a panel of distinguished physicians, scholars, and leaders in medicine and medical education. We hope you'll stick around for the panel, which begins at this same link at 10:15 a.m. Eastern Time. This morning, following Dr. Plews-Ogan's keynote, we will have time for a few questions from the audience. The chat is disabled, so if you have questions to ask, please do so through the Q&A function in Zoom, and we'll present your questions to Dr. Plews-Ogan in the conversation. Also, with support from Wake Forest Program in Interpreting and Translation Studies, we're offering live interpretation of today's session in both Chinese and Spanish. So if you'd like to access that interpretation, please click on the interpretation icon at the bottom of your Zoom screen. Finally, several of you have registered for continuing medical education credits for this morning's session. For those of you who would like to register or sign up for CME credits, you may do so by amending your registration in the email you receive with these links. 2 credits are available for a small fee. Now, it is my distinct honor this morning to introduce our distinguished speaker, Dr. Margaret Plews-Ogan, Brody Professor of Medicine and the co-director of the Wisdom and Wellbeing Program at the University of Virginia School of Medicine. Dr. Plews-Ogan was a founding director of the Center for Appreciative Practice and is a leading expert on the role of wisdom, well-being, and positive emotion in the practice of medicine. She's the author of many articles and 3 books, including Choosing Wisdom, Strategies and Inspiration for Growing Through Life-Changing Difficulties. Her talk today is entitled Wisdom Out of Adversity, Fostering Wisdom in the Wake of Critical Events and Circumstances. Welcome, Dr. Plews-Ogan.
Thank you, Michael. Thank you so much. I am really excited to be able to share some ideas with all of you, ideas on character and virtue in the profession of medicine. So let me get my screen share going here. I have to say I've had such a wonderful time participating in the other talks. It's just terrific to be in this interdisciplinary context. So today I'm going to focus on the virtue of wisdom. In particular, why wisdom may be a valuable construct to apply to professional formation in medicine, a true north, if you will. I'll talk briefly about what we know about wisdom and its development, and then I'll drill down on even further into the role that adversity may play in the formation of wisdom, and what that might mean in the education of medical students and residents, and in the fostering of wisdom in practicing physicians. I'll wrap up with some thoughts about how medical training might change if wisdom were considered the true north, if the focus of professions education was to create both the capacities and the opportunities to integrate our experiences with our knowledge and technical expertise in a wisdom-generating way. I don't have any commercial interests or conflicts. And I want to start with a story. So it was 4 a.m. 25 years ago. I was an intern doing the pre-round tasks that interns do of IV restarts and blood draws for morning labs for my team's patients. I was provided with a somewhat jumbled cart of supplies for these tasks. This was pre-patient safety. Vials of saline for central line flushes after blood draws, lidocaine for IV restarts, needles, and blood tubes. And as I finished drawing a set of labs off of a central line and flushing it with what I thought was saline to prevent the line from clotting, I happened to look down at the vial and realized to my horror that it was lidocaine, not saline. Although unlikely, there was a finite possibility that this could have caused an immediate fatal arrhythmia. I waited for what seemed like hours but was actually only a minute or two, watching the monitor of this unconscious, gravely ill patient, and nothing happened to the patient. The same could not be said for me. In the wake of that near miss, I nearly quit medicine. At times, I felt like I could not go on even with living. It was months, years really, before I had fully worked through that event. However, what I realize now was that I received in the aftermath of that event a crucial level of peer support that at the time was a matter of luck rather than design. Luck in the form of a particularly persistent, forward-thinking, supportive senior resident who helped me to be honest, to make positive changes in the wake of that incident. We fixed that container of supplies, for one thing, and enabled me to go on as a better doctor because of that event, no doubt launching my career in patient safety. And the rest came over years, discovering ways to build my resilience, like mindfulness, ways of enhancing my platform of positive emotion, and my interest in how to help people grow and change for the better in the wake of adversity. Mine is just one example of the kinds of challenges that face physicians in their work today. Both the necessary stressors of caring for people who are suffering and the adverse events that do occur through one's career, as well as the unnecessary stressors like not enough PPE, a lack of essential supplies to do our work, increasing events of disrespect and bigotry directed toward us, all contributing to an already challenging profession where mistake can be a disaster and where we are exposed to the trauma and suffering of others every day. But whether a clinician does well or poorly in responding to the stressors of their work, or whether they're able to act wisely in really tough circumstances, is not something we should leave to chance. There are things we can do, critical things, that we can do now to build the capacities and the skills needed to do well and to do good. So let me back up a bit. Why are we even talking about character in medicine? Well, I actually believe that some of the fundamental particularities of being a doctor necessitate character to fulfill our responsibilities. And what are those particularities? Well, first, there's a great deal more uncertainty and ambiguity in medicine than perhaps the general public would like to know, or perhaps we want to admit. Bill Haslam on Thursday at this conference said something like, "I wish somebody had told me how hard this was going to be." I think our students in medicine might say that same thing. Second, we are plagued by biases that cause our thinking to go wrong and our actions to be wrong. And the consequences are tragic. Intellectual humility and metacognition are critical to avoiding those pitfalls. Third, this is an intensely relational profession. Without relationship, frankly, we are nowhere. And that relationality has accountability with it. We need to be trustworthy. Fourth, we are in a position of profound power because we are responsible for those who are particularly vulnerable. The trust that requires is something that is sometimes breathtaking. Fifth, we have seen how a lack of focus on justice and the greater good in this influential profession can have dramatic influences on society. There is a clear through line, in my opinion, from how we have conceptualized and operationalized our role as physicians in society to our current situation of health disparities, of inequity in simple access to healthcare, not to mention the upstream problems of poverty that we as a profession have failed to influence. Sixth, physicians are more often than not balancing multiple virtues, having to decide which to employ in particular situations. When should we employ honesty versus hope, or certainty versus prudence? And then finally, physicians themselves are therapeutic tools. The age-old question, can you be a good doctor and be a villain on the side? Or do as I say, not as I do? It doesn't work for a doctor. Overall, I feel we've become infatuated with the technical aspects of medicine, and there are breathtaking achievements that have been made. And at the same time, there's been a pernicious takeover of medicine by business. And there has been loss. Ask any patient or doctor. a loss of time, a loss of compassion, a loss of focus on relationship, a diminished appreciation of the complexity and ambiguity of the decisions we make, and a loss of focus on justice, equity, and the public's health and well-being. The good news is that we seem to be waking up to recognize those aspects of medicine that were cast aside and allowed to wither from inattention. Things like compassion, trustworthiness, humility, tolerance for ambiguity, valuing relationships, and a focus on the greater good, justice, and equity. We are more than ready to take a step forward. Importantly, the literature has begun to reflect this readiness to move beyond the competencies and into the being of doctoring, to thinking, acting, and feeling like a doctor. And Kraus, researcher in professional identity formation, suggested then that the fifth level be added to Miller's pyramid to reflect this fifth identity formation stage. And this all begs the question, what exactly are we becoming? The good doctor, a fully integrated moral doctor self, knowledgeable, competent, caring, compassionate, honest, trustworthy, a wise physician perhaps? Is wisdom a useful conceptual model? For some, wisdom might just be a bridge too far. In fact, it's not for everybody. Some would go for the burger, myself included at times. But in the realm of being a doctor, wisdom might be, in fact, exactly what's needed to be worthy of the trust put in us. And here I'm talking about phronesis, or practical wisdom. As Barry Schwartz likes to put it, it's the capacity to do the right thing at the right time, in the right way, for the right reason. But why wisdom in particular? Well, first, it actually brings together components of being a good physician that we have been struggling to unify under one conceptual model for quite a long time. High levels of knowledge and technical expertise with compassion and trustworthiness and humility and an orientation toward the greater good. Wisdom is considered an uber virtue, if you will, that virtue that orchestrates all the other virtues and balances them in conflicting contexts. It's a lifelong endeavor. No one ever achieves wisdom entirely, and it's applicable, therefore, at any level. It involves the integration of experience, including difficult experiences that physicians are involved in every day. So let me ask you to, for a moment, explore your own understanding of wisdom. Take a minute and think about a person whom you would consider wise. This might be your grandmother, a beloved teacher, a famous leader, or an author. Bring that person to mind. And now, when you have them in mind, I want you to ask yourself, what about them made you think about them as someone who is wise? What qualities do they have that made you say they're wise? Name a couple of qualities in your mind. And then finally, ask yourself, how do you think they got that way? What in their life contributed to their wisdom? So I've done this exercise all over the country, and although the people who get nominated as your wise person is quite varied, it could be your grandmother or it could be Abraham Lincoln, but the qualities for which they're chosen are amazingly consistent. Humility, compassion, trustworthiness, able to see the bigger picture or the deeper meaning of events and circumstances, high levels of knowledge and skill, but the ability to apply that in the right way for the right reasons. Wisdom researcher Monica Ardelt has done some really nice work on delineating what characteristics exemplify a wise person. And she's separated these into 3 domains. In the reflective domain, wise people can see things from many perspectives and rise above their own perspectives when considering a situation. This requires self-awareness and self-insight. In the cognitive domain, wise people are characterized by their ability to see the deeper meaning and see the bigger picture, by their ability to apply knowledge and skills to the right action. They have a tremendous ability to deal with ambiguity and complexity and resist the effort to try to make something black and white that is in fact not black and white at all. They are humble and aware of their vulnerability to bias and to mistakes. In the affective domain is essentially defined by compassion. Wise people are compassionate. And finally, they have a focus on the greater good. And in their actions, they try to make the world a better place. What I want to note is that wise action actually takes more than knowing what should be done. It means actually being able to do the right thing in highly challenging situations. It takes things like emotion awareness and emotion regulation, metacognition, and practices that allow someone to act wisely in a really charged situation. So what might wisdom look like in medicine? A physician who can see things from multiple perspectives is one who can actually see things from the perspective of the patients that they're treating and from the society that they're trying to serve. They're highly knowledgeable and technically skilled, but they can apply that knowledge and skill in the right way to a particular highly complex situation or patient. They can see the deeper meaning of what's going on and help patients make decisions in really difficult circumstances. They can balance conflicting values to make the best decision in these tough circumstances. They can tolerate ambiguity and uncertainty, and they resist the all too frequent error of making something black and white that it's not. And they're humble and aware of their vulnerability to mistakes. And finally, they're compassionate, even when it's hard. And one thing that comes out really consistently about wise people is they're not perfect. In fact, becoming wise is really all about how one handles one's imperfections rather than about being perfect, which is a really important distinction in this domain. Wise people are humble and they're very aware of their vulnerability to mistakes, but they also see their mistakes as an important window into how to get better. And so they look at them really carefully. They take them in and they learn from them. It turns out that wisdom actually has a very special relationship with adversity. It does appear from the 20 or so years of research into how wisdom is developed that adversity is in fact a particularly fertile opportunity for the development of wisdom. Jonathan Haidt, in his book, The Happiness Hypothesis, he poses the question, if you as a parent could take an eraser and erase all the adversity that your child would face throughout their life, would you do it? It's a provocative question. Tedeschi and Calhoun were the first to study what is now termed post-traumatic growth, the positive effects of adversity on human growth, the results of which they postulated to be wisdom. And in fact, there is now evidence to suggest that adversity can result in wisdom and is a particularly fertile opportunity for wisdom to emerge. But wait, not everyone gains wisdom from their challenging experiences. So what makes the difference? Is it what we bring to the table when adversity strikes? Or is it what happens during and after, how we process that experience, our social supports? Well, research thus far suggests that it's a little bit of both. There are likely predispositions, capacities, ways of seeing events that predispose us to wisdom formation through experience. These are things like openness to experience, positive emotion, gratitude, forgiveness. And there are also ways of reflecting on and processing experiences that are associated with wisdom gained. In fact, Westrate and Glick have studied in a really beautiful way how individuals process difficult experiences. And their findings suggest that a type of processing that they call exploratory processing, which is really aimed at meaning making and at personal growth, was associated with wisdom gained. Whereas redemptive processing, which is really aimed at positive emotional reframing or resolving the event, was associated with adjustment. So this exploratory processing, which is characterized by asking oneself, what meaning does this event have for me and how does this change me, is more effortful and perhaps less common, but the outcome, wisdom gained, positive growth, is worth the effort. So what does the wisdom generating process look like in physicians? So this is from a mixed methods study of over 70 physicians across the country who had made a serious medical error. The study included a qualitative analysis of physicians' journey in coping with a medical error, along with the quantitative measures of wisdom, post-traumatic growth, gratitude, forgiveness, spirituality, and openness to experience. The path through adversity to wisdom gained is shown here. And let me be really clear, this is not a linear path. This was iterative, moving back and forth through the various elements over and over again as people coped with these challenging experiences. It did begin almost universally with a radical acceptance of what had happened. It's not your ordinary acceptance, but a really clear-eyed acceptance, taking in the event that had occurred. The second element we called stepping in, to describe a really active taking hold or taking responsibility for the response to the event. For some, that element was defined by disclosure and apology to the patient or family. For others, it was diving deeply into learning everything they could about what had gone wrong and why. The third element we termed integration, because it was this element where the physicians were really struggling with how to integrate this event into their understanding of themselves. For example, how can I be a doctor, a good doctor, if I'm capable of making a mistake like this? How can I be decisive when I'm now so aware of my vulnerability to making an error? The fourth element is where the physician is now trying out a new narrative, the imperfect but good doctor. What does that look like in reality? How does it change how I do things? And finally, the last element was really about wisdom gained, where the physician was able to reflect on their experience and how it had changed them, and then somehow share that forward as more compassion for others, as teaching about it, as a renewed sense of meaning and strength and purpose. And in this study, there were a number of things that were correlated with the wisdom response to adversity. Positive emotions of gratitude, forgiveness, and openness to experience. But also positive coping skills, reflective skills, being able to talk about it, seeking support, and honest feedback, not just support, really honest feedback. Finding meaning in the event, having social supports to carry them through, having a moral context that helped them to do the hard thing when they needed to. And then this capacity for helping others, teaching about it, making positive change. So evidence is beginning to emerge that suggests that there is a way of moving through challenging experiences that generates wisdom, and that there are individual capacities as well as ways of coping and being supported in the moment that make wisdom generating response more likely. There's also some evidence that this process is circular, and it becomes a positive reinforcing loop. So stepping through this schematic, when an event occurs, if we have the positive coping skills, the reservoir of positive emotion, and the social supports and the moral context, we can meet that challenge in a wisdom-generating way, a virtuous cycle that results in increased compassion, helping behaviors which then reinforce our own resilience. The opposite can occur if we are bereft of positive coping skills, positive emotion, or social supports, leading us to negative coping and a negative cycle of enduring distress, burnout, and further reduction in resilience. So is there a way we might better prepare our students with the capabilities for a wisdom-generating response to the experiences they will face in their professional lives? People have begun to think about what it might look like if we had wisdom rather than simply knowledge acquisition as a focus in higher education. This writing out of the Jubilee Center and the Oxford Character Project depicts wisdom as this uber virtue, the orchestra conductor, if you will, that helps to orchestrate the right application of all the other virtues. And most recently, what was for me a really helpful piece by Michael Lamb, thank you, Michael, that synthesized strategies for character development, habituation through practice, reflection on personal experience, engagement with virtuous exemplars, dialogue that increases virtue literacy, awareness of situational variables, moral reminders, and friendships of mutual accountability. So now thinking about what we know about wisdom, about how it is developed, and reflecting on some of these Aristotelian strategies for character development, I want to explore how medical education might be different if wisdom were the focus. So remember, first of all, high levels of knowledge and technical skill do not equal wisdom. At present, our training and evaluation are focused on knowledge and technical skills. And the way we train is also directed toward knowledge and skill. How would things change if wisdom was true north? I believe actually it would result in, to a certain extent, a kind of flipped curriculum. Right now, the knowledge portion of the curriculum is front and center, and everything else is pushed to the side, compassion included. If wisdom were the focus, knowledge and technical skill would be important, but the acquisition of the skills and practice required to apply that knowledge with justice and in challenging situations would be the really critical in-person foundational curriculum. Since, if you think about it, the simple acquisition of knowledge can be self-taught almost, but the application of that knowledge requires experience and reflection, discussion, and mentoring. Reflective skills, compassion training, perspective taking, emotion awareness and motion regulation, metacognition, awareness of vulnerability from mistakes and learning from mistakes would all be the essential skills of this foundational curriculum. There would be a focus on longitudinal integrated experience, reflected on and mentored, since the development of wisdom is a longitudinal process, depending on repeated experience that is reflected on and then tried again. The atmosphere of learning in medicine would be focused on the opportunities brought forth by ambiguous situations, areas of conflict of values, mistakes, those areas that are particular opportunities for wisdom gained. As an example, how might our teaching of clinical reasoning be influenced by the impact of wisdom as true north? This diagram by Grossman and Dorfman is one example of what might change in how we teach clinical reasoning, what might be added. Right now, we don't emphasize these four aspects of wise reasoning. A new emphasis on integrating others' perspectives, patients, colleagues, and on the recognition of uncertainty, on intellectual humility, would transform our teaching of clinical reasoning, emphasizing where am I uncertain, where might I go wrong, consider the opposite, would all be steps in our teaching of clinical reasoning prospectively that would be transformative. In fact, we are experimenting with a new way of doing M&M, Morbidity and Mortality Conference, that's focused on diagnostic errors, incorporating some of these concepts that define wise reasoning and helping residents grapple with situations in which their thinking went wrong, dissecting the biases that put them at risk and the debiasing strategies that may mitigate those vulnerabilities. How would clinical teaching in medicine change with a wisdom focus? We would make our intellectual humility transparent. Right now, we rarely expose our doubts. We would actively and overtly manage ambiguity. Again, we often strive to make things black and white, a common cause of errors. We would practice perspective taking overtly with our students and residents. What would this look like from the patient's perspective? We would practice overtly wisdom skills like emotion awareness and regulation. I'm taking a deep breath now to calm my emotions before I make a decision in this situation. Compassion, curiosity rather than judgment. We would create opportunities to reflect, lots of opportunities for reflection on our decisions and our actions. We would overtly utilize debiasing strategies like consider the opposite, change my mind, ego decentering, and we would usually utilize mistakes as opportunities as often as possible. A focus on wisdom may also change where we focus our attention. An intentional focus on critical incidents becomes a key change in our training. Shepherding that process of hard-earned wisdom becomes a priority. Many of you are familiar with Keegan's developmental stages of identity formation. The relevant stages for medical students are acting the role in stage 2, creating a socialized mind, trying to fit in stage 3, and internalizing and personalizing the identity in stage 4. The integration and development of identity happen actually through crises and challenges and situations of dissonance. That's where the action is. For example, if we come in with the notion that physicians are healers, and then we have our first patient death, that is a crisis that will precipitate a broadening and a deepening of our understanding of who a physician is. If we have a notion that a physician is perfect and we make our first mistake, that is a deep challenge to our understanding of who a physician is. So shepherding that process of hard-earned wisdom becomes a priority for a teacher. Recall that acting wisely means not just knowing what to do and how to do it, but being able to do it in highly charged, difficult situations. And this takes self-awareness and self-mastery. It takes skills and practice. And so we would focus on those skills and practices that help us to act wisely in these tough circumstances. Mindfulness, emotion awareness and regulation, practicing curiosity, practicing compassion. So I want to spend the last few minutes talking about a couple of innovations that we're exploring at UVA. The first is what began as the Phronesis Project in the medical school, a curricular innovation organized around wisdom as the true north, with the goal of fostering the development of practical wisdom in our medical students as they progress through the 4 years. The major pillars of this redesign included 1, longitudinal patient relationships, 2, longitudinal mentor relationships, 3, wisdom practices, and 4, a focus on the application of knowledge and skills to particular clinical cases. This is the anatomy of the Phronesis Project. And on the right, you can see the wisdom-related capacities that each of these pillars was intended to foster. Each student is matched with a patient family that they follow for all 4 years of medical school. They're also matched with a Phronesis mentor, a coach, who grounds their professional identity formation in a wisdom framework, teaches them the basic clinical skills, clinical reasoning, physical exam, relationship skills, and then follows them throughout the 4 years, reflecting regularly with them as a group and individually on new experiences and on helping them process critical incidents. So the crucible of the student's professional formation is this patient-student relationship. It's a 4-year-long relationship that begins with the patient telling the student their story, the story of their life, essentially. It includes house calls, clinic and hospital visits, advocacy for their patient, presence at critical times in their patient's lives, and it becomes the crucible for pretty much everything that the student is learning. Research is beginning to show that cultivating positive emotion, I'm calling them now wisdom practices, like curiosity, forgiveness, compassion, gratitude, and openness, can help us not only just withstand, but actually become better as we face challenges. It takes work to firmly establish these emotions. We are intentional in fostering these positive attributes, hoping to build a platform such that when challenges occur, as they inevitably will, we have the best chance of responding in a way that will generate wisdom rather than hate or further suffering. And we've begun to teach these positive habits, or wisdom habits, as I'm now calling them, across the medical school and even across the health system. We are also intentional about our focus on processing critical incidents, with a focus on exploratory processing, as Gluck and Westrate have described, and the intention toward the desired outcome of wisdom gained from these tough experiences. So we actively teach debiasing strategies. We use early modeling of mistakes as opportunities, early modeling of intellectual humility, and open, rigorous examination of adverse events. And this all happens in the social network of the Phronesis group, the group of 6 students and a mentor, which is consistent throughout the 4 years. Wisdom researcher Jack Meacham talks about how wisdom is fostered in a specific kind of learning environment or learning community. He calls it the wisdom atmosphere. I love that term, in which people are free to question and to work actively in that space between too confident knowing and paralyzing doubt. It's a community where we continually ask ourselves, was that wise what I just did? Of course, none of us will ever completely embody wisdom. And so it's a continual striving, integrating, growing process for all of us. The faculty involved are personally engaged with the identity formation themselves, reflecting on their own identity, their own wisdom seeking as it continually develops through the lifespan. The second thing I wanted to share with you is that we also have begun a second experiment, this one with practicing health professionals in the health system around wisdom development. So it seems obvious that character development in medicine can't just occur with the students. It needs to happen across residents and faculty and staff in the practice environment. The use of the language of character, the modeling, the support, the exploration in the wake of critical events, all of this being of doctoring is mainly learned in context and through modeling. And maybe even more importantly, this character development of the individual must be accompanied by the development of character of the organization, the medical school, and the health system. Trying to practice morally or wisely in an immoral or unwise system creates moral distress, learned helplessness, and in the end, a collapse of the character education. Leaders of our educational and our systems of care must be trained in the same true north. We have seen already the power of the hidden curriculum. Changing that has not only to do with character education for the individuals, but the fostering of character in the organization. And so we've begun a wisdom and well-being program in the health system, and this program has three focuses. First, to help individuals and units have a healthy internal set of resources, a platform on positive emotion, openness for engaging with uncertainty, and an ability to bring out the best in each other. Second, we are committed to identifying and eliminating unnecessary stressors in the healthcare environment, things like insufficient supplies, inefficient or unsafe processes and environments, understaffing, unrealistic work expectations, bigotry, and discrimination need to be fixed. This is not just an individual responsibility, it's an organizational responsibility. When clinicians don't have the time, equipment, or personnel to meet their professional or moral obligations to their patients, they will suffer a moral injury. When the organization does not attend to justice and equity and social responsibility, the professionals are not attending to their moral obligations of the greater good. And finally, we are committed to creating a supportive environment as an organization, paying attention to the critical events and how they are managed, adverse events, mistakes, difficult conversations, assuring that when a critical event occurs, people have the necessary support and guidance to move through these experiences in the best possible way. This is the anatomy, essentially, of the Wisdom and Well-Being program, but essentially it consists of a peer support program, of resilience training, including responding to critical incidents, and then systems level work to eliminate unnecessary stressors, including bigotry and disrespect in the work environment. In medicine, we like to talk about bundles. We have quality bundles and safety bundles, and we now have a wisdom and well-being bundle. And these are the components of the bundle that we use in training and supporting individuals in the healthcare environment. Because we know that this capacity to act wisely is built through skills and practice, training and experience, and it's fostered in a wisdom environment. And this is what one of our team resources looks like. We use the stress continuum to enhance people's awareness of the stress that they are experiencing in the moment. And then we give them some critical skills and resources to help them to manage their work life in the best possible way, both individually and as a team. So in summary, going back to my opening story, The professional formation, the capacity to learn and grow in the face of challenging circumstance and to integrate experiences in a way that builds character, in this case, wisdom, should not be left to chance. We know that we can do better in both preparing our students and in supporting our health professionals to think and act wisely in the critical work that they do. We also know that we can inform our organizations to think and act wisely with justice and equity and with attention to the health and well-being of the population at large. Thank you very much for letting me share these thoughts, and I'm looking forward to the question and answer time.
Great. Thank you so much, Dr. Pluzokin. That was a terrific talk. That was really fantastic. I think so relevant for our conference and also for our larger culture. So thank you for sharing your words of wisdom and also your example of it this morning. We do have time for questions from the audience, and I know several have already submitted questions in the Q&A function. If you have a question, please use the Q&A function in Zoom, and we'll try to field as many questions as we can before our time is up this morning. So our first question, Dr. Pluzokin, is this. What are the most challenging obstacles to developing wisdom in medicine and medical education currently?
Ooh, that's a big one, Michael. I think, honestly, the most challenging obstacles may be that this is a big lift. There are lots of moving parts in trying to promote wise action and wise thinking in the healthcare environment. And I think that's why in the talk I tried to bring together both the kind of education piece of this, which is inextricably bound to the practice environment. And what we've suffered from, I think, in medical training in general, and in other professional training as well, I think, is this disconnect between what we talk about when we, talk in a classroom and what the students experience. And so I think as educators, we need to think really hard about how to connect what we're purporting to be important in the training of physicians to what they experience in the training environment. And I think we necessarily need to get involved in making that training environment better, more just, more equitable, more compassionate, more, all the things that we would talk about in wisdom formation. I think the other, probably if I were thinking like on an individual student basis, I think internally, one of the toughest hurdles to overcome is our perfectionism. And if there's one thing, perhaps, that I think would enhance our ability to be compassionate, thoughtful physicians, it would be this notion that compassion is for us as well, that we are not perfect, that we are capable of the old saying, if you can't forgive yourself, you can't forgive other people. There's really truth to that. And so developing those inner capacities from day one of medical school, unfortunately, I think to a certain extent, whatever hasn't been beaten out of the students before they get here, we beat it out of them in medical school by putting them in very high pressure environments where it's all about being right. And not as much about examining the ways in which your thinking went wrong. And so I think creating an environment where, like Meacham would say, we can be in that space between not being overconfident and not being paralyzed by doubt. Getting the individual to be able to work in that space is, frankly, it's a lot about forgiveness and honesty and dealing with imperfection.
Excellent. Thank you. Well, one question actually comes from both Sabina Jamil and also Gare McCullough, and it's about the relationship between phronesis development or wisdom development and the goals of professionalism. There's a lot of overlap, perhaps, between those two goals, but also maybe some tension. So how do you actually navigate the sort of goals of professional development with the goals of wisdom development in clinical practice and teaching?
So I think that's why I am conceptualizing the top of that framework, and I guess what we're all after, the good physician, which is really what professionalism is about. It's being that good physician even in trying, challenging times. So I don't actually see them as separate. I think we need to get really, and frankly, this is why I became so interested in wisdom as a virtue, because it actually brings together these things that in medicine we have separated, right? We've talked about professionalism as though it's separate from medical knowledge and procedural skills, which is separate from compassion, and I think we suffer from that, those separations. If we, and it's frankly, it's always driven me a little crazy. In fact, not too long ago, I had a patient say to me, well, if my surgeon, can be compassionate, that's great. But if I can't have that, I just hope they're a good surgeon, And I thought, oh my goodness, how have we allowed that to be separate? The technical skills and the medical knowledge should not be separate from the compassionate delivery of the care that we're providing, and from these complex sets of clinical reasoning that we have to go through in order to apply that knowledge and skill in the right way. So I don't separate them. Our professional formation, our professionalism is intimately tied together, and that's why I actually use the wisdom framework, because it's the only thing I've found that actually brings all those things together and allows us to conceptualize things as one.
Great. I have a question now from Alicia Detroit, who thanks you for an excellent talk and asks, how do you feel about other healthcare team members, such as PAs or nurse practitioners in team-based care, and how they can contribute to the growth of wisdom in the medical setting?
So wisdom is an absolutely universal concept in terms of what profession it could apply to and what human being it can apply to and what situation and organization. So I think it's, in fact, the work that we're doing in the health system, so outside of the medical school education work, the work we're doing with wisdom and well-being in the health system is interdisciplinary. And we have nurses involved, and they're talking about wisdom. And what I really love about it is that now you have an interdisciplinary team that's all kind of using this same language of, was that wise what we did? Was that a good decision we made? And boy, that's where you can really get a team that can work together to make things better.
Great. Well, one question focuses on the tolerance of ambiguity that you mentioned as part of wisdom. And so to what degree do you think that this concept resides currently in practitioners and faculty? And how do we might develop that concept further as we think about expanding wisdom in the medical profession?
Yeah, so like I know the AAMC is really interested in actually thinking about whether we should be even selecting students. So right now we select really smart students who have done very well in all kinds of ways, but they don't all have high tolerance for ambiguity. And as they move toward, so the first, if you have a traditional curriculum where the first 2 years are mostly, book learning, thankfully a lot of medical schools have moved beyond that kind of approach, but that book learning, the medical knowledge part, tends to, that people who can't tolerate ambiguity tend to do just fine in the book learning, because there's always a right and wrong answer on the test, right? And then they hit clinical medicine, they're like, holy cow, this is not what that was the quote I had from Thursday. Like, I wish somebody had told me it was going to be this hard. Some students really struggle with the ambiguity that defines essentially most of medicine. I encourage my students when they're in their clerkship year in medicine, their clerkship in medicine, I say, you know what? You're going to find ambiguity in every single decision we make. Maybe 20% of what we do has really good evidence that you can say, okay, I'm making this decision in this place, and I'm doing this. The other 80% is like, well, and there's just lots of ambiguity in what we do. And it drives the students crazy who are not good at dealing with this. So I think the more honest we can be about that ambiguity and the more we can help people to navigate that. And I don't mean just kind of live with it. I mean actively manage it, right? One of the things that, one of the fairly common diagnostic errors is when you try to resolve that ambiguity too quickly. So you have a patient who's presenting with somewhat ambiguous symptoms and signs, and you make the mistake of jumping to a particular diagnosis, and essentially you eliminate from your mind any of the symptoms or signs that don't go with that, right? So you're trying to resolve an ambiguous situation into something that's clearly defined, and that's the most common diagnostic error. Managing ambiguity means being able to hold that all while it's still ambiguous, to hold it right in front of you, top of mind, and wait, because and get the additional information you need to be able to resolve the ambiguity in a conscious and much more likely to be correct way. So this is a really important clinical capacity that students need to learn. And if they don't learn it, they're going to be in trouble in some point. So I think it is very important. It's also, it's not just something that we would be kind of fostering early on. We need to be modeling it overtly. When we make decisions as experienced physicians, we need to be saying, you know what, I'm really not sure what's going on in this situation. Here's my full differential. We're going to hold this all together and get more information over the next 6 hours. And then some of this may become less ambiguous. I hope that answers the question, but I think it's a really important thing to be attending to in medical training.
And I love the connection between humility there, but also patience as one important virtue that might support wisdom in this context. That's really
absolutely. It's very uncomfortable, especially when it's someone's life. It requires this level of attention that is constant until the ambiguity is resolved, and that can sometimes be quite a number of days, but certainly hours before we have a great diagnosis.
Excellent. Our next question comes from Brewer Eberly, who has also started a similar initiative called Phronesis with his medical students. They actually use a discussion of wonder and beauty to start their series, he says. So do you see a link between wonder and wisdom formation? And are students and residents first wooed by beauty of wisdom on their way toward more development? Or are there other ways you capture their imagination in thinking about wisdom in the medical context?
Oh, what a great thing. And, I have to say, it's one of the things I'd like to add more in our training, because I don't think we do enough. I think the way that maybe we incorporate that wonder is in our focus on curiosity. So when you ask a curious question, there is kind of an open-eyed, wow, I wonder why. That's actually the question we teach in order to open up that curiosity. I wonder why. And there is kind of if it's true curiosity, there is an openness to this amazing situation that you don't really totally understand. So I think that's how, and it's a really important, I think it's a really important virtue to foster. And I guess the other way into it is gratitude. And that is something that we foster. But I think it's a great idea to use beauty and wonder as kind of a starting point.
Great. Well, our next question comes from a student of mine, Rucker Robinson, who aspires to be a physician as well, who thanks you for the talk and asks, you've talked a lot about how adversity might help shape wisdom. So given this year in the pandemic, we've all faced significant adversity. How does that experience actually shape doctors' sense of wisdom? And will it change current and aspiring physicians to think about wisdom differently, or would it actually kind of re-entrench some of the sort of systems concerns that might previously been present?
Great question. And I would take you back. I went back immediately to that really busy slide that kind of tried to portray the pathways that people can take when they're faced with a challenging circumstance, right? And the wisdom generating pathway requires a lot of positive emotion and a moral context and all that stuff. And then you get into this virtuous cycle. I think that some physicians in their experience through the pandemic have actually developed a greater appreciation of the work that they do, of the essential nature of the work that we do. They have maybe, I hope, had a refocusing on justice and equity that may have been lost, and now it's in the national conversation, and it's also in the conversation in medicine. There may be ways, I think we talked this morning about how wonderful it is that there are so many able to be at this conference. And it's because of our virtual, the kind of this explosion of our capacity to reach out to one another in a virtual context. I also think it has redoubled, at least in our health system, and I think in many, our focus on making things better in the way that we deliver care. Whether it's justice or equity, or whether it's a refocusing on compassion. I can't tell you how many physicians I work with who went through the early experience where compassion was incredibly challenging because there were no family members there. Everything was off an iPad. You had patients dying without any family. It was an incredible challenge, but it did kind of bring people back to their roots of how to be compassionate in really challenging situations. So I think it can go either way, and it's going to go both ways, right? It's going to harden some people, and it's going to reinvigorate or reimpassion other people to do better. And I hope the majority of us are impassioned to do better.
Great. Well, it's a great note for our final question, which is this. What advice would you give to medical students or pre-med students about cultivating wisdom and character in their education?
Start dealing now with your perfectionism. Start practicing compassion and forgiveness and mindfulness and curiosity about everything. You're entering an incredibly wonderful profession. We need you, and we need your open minds and your new vigor. So we welcome you to the profession, and it's never too early to start practicing those virtues.
Excellent. Well, thank you so much, Dr. Pluzak. That was a terrific talk and a great Q&A. And I think we're just so grateful for your own vision and example of humility and curiosity and wisdom in today's talk. So thank you very much for that.
Thank you, Michael.
We do have time now for about 15-minute intermission before we start our panel on character and medicine with some really terrific speakers coming up at 10:15 Eastern time. So we hope you'll join us here on this same link in about 15 minutes for our panel. So thank you all very much. Hello, everyone, and welcome back or welcome to our panel on character and medicine. My name is Michael Lamb, and I'm the Executive Director of the Program for Leadership and Character here at Wake Forest. We have a terrific panel lined up for you this morning, so we want to jump right in. But first, a quick note before we begin. While we had audience Q&A for the keynote, we will not have Q&A for this panel given our limited amount of time. So with that note ahead of us, I want to introduce now our moderator for today's panel, Dr. Julie Freischlag. Dr. Freischlag is CEO of Wake Forest Baptist Health, Dean of Wake Forest School of Medicine, and Chief Academic Officer of Atrium Health Enterprise. She's a dynamic leader, an award-winning teacher, and renowned scholar. A member of the National Academy of Medicine, she is currently president-elect for the American College of Surgeons and has published more than 300 manuscripts, abstracts, and book chapters. We're delighted she can be here to moderate our panel this morning. Dr. Freischlag, over to you.
Great. Good morning. It's great to be involved with this panel. I was so motivated by an excellent talk that we just received all about wisdom. So I have a panel that I think will be able to expand on wisdom and character in medicine. So on our panel will be three amazing leaders in medicine. Dr. Bart Curlin, who's professor of medical humanities at the Duke University School of Medicine and School of Divinity. And he is the Josiah C. Trent Professor of Medical Humanities in the Trent Center for Bioethics, Humanities, and the History of Medicine at Duke University. We also have Dr. Patrice Harris, the outgoing president of the American Medical Association. She was the 174th president of the American Medical Association and currently leads the AMA's opioid task force. She is also an expert on children's mental health and childhood trauma. And our third panelist is Dr. Adina Collette, who's the director of the Current Institute for the Transformation of Medical Education at the Medical College of Wisconsin. She is the Stephen and Shelley Royal Endowed Chair of the Robert D. and Patricia E. Current Institute for the Transformation of Medical Education at the Medical College of Wisconsin. And she is also an adjunct professor in the Department of Medicine at the New York University Grossman School of Medicine, where she was the founding co-director of the program on medical education, innovation, and research. So I want to welcome all three of you and appreciate you being here. And we hope this will be an enlightening discussion about character in medicine. So why don't we start off with some personal questions so we can learn a bit more about the three of you and where your thoughts are and how you've come through your education in medicine. We heard a lot about compassion and not being a perfectionist and learning how to be the best doctor you can be through wisdom. So why is character so important for medical professionals, including doctors? Why don't we start off with you, Dr. Curlin?
Thank you. It's good to be with you. Classically, there have been thought of as there being three professions, the law, medicine, and the clergy. And what makes these practices different is that they respond, each of them, to a profound human vulnerability, or in defense of which people need a trustworthy advocate. So if you're threatened by the state or threatened by neighbors, by hostility, having an attorney who will be in solidarity with you and will represent you is critical. If you're facing eternal judgment, or you're facing just the question of how to be rightly related to God, it's critical that you have a trustworthy clergy member. And if you're facing, as all humans are facing, illness and injury, it's critical that you have physicians or other practitioners of medicine, healers, that you can rely on. And so I think that vulnerability heightens the need for virtue in a way that's not true potentially of practices where the person is not as vulnerable, a person at the local shop, for example. But in my own work, of course, I've taken care of hospice and palliative medicine patients. These are patients who are extraordinarily diminished in their health and vulnerable, and have to give themselves over to my care, and have to entrust themselves, if they're going to receive my care, I believe they'll have to trust themselves with confidence, one hopes, that I will be a good steward of that, and I will care for them in a way that fits what morality requires and fits what their health requires.
Thank you. Dr. Harris, do you want to expand on that, how you see character for medical professionals?
I do. And first of all, I am honored to be a part of this discussion today. And what an important time to be having this discussion. I know the discussion this morning was related to medical errors perhaps, and issues around the individual physician as relates to adversity. But I think we can all say that the COVID-19 pandemic and all of the related interchanges around the pandemic, issues around police injustice and structural racism. And I live in Atlanta. And so what we've just experienced this past week. And so it's critical, again, for us as physicians in the medical profession to have this conversation, but certainly it's in the context of a larger conversation. But, physicians are granted extraordinary privileges, right, to intervene in patients' lives. And as a psychiatrist, I think I see that privilege even more heightened. Patients entrust us with the care of their bodies and their minds. They tell us information that they don't tell their closest relative. And so with that privilege comes responsibility and accountability. We heard about that this morning, and certainly wisdom. And I love that. And I love that it was defined, because as we think about wisdom and virtue, these could be sort of nebulous, abstract concepts. And it's so important for them to be defined. And I really like the concrete action steps that were discussed this morning. And so that's what we have to be about now, I think. We have to have these conversations, define these conversations so we can have a shared understanding. And then what are the action steps to get us to where they need? Because I believe, and we say at the AMA, that there's a moral character to the interaction between patient and physician. And so we have to make sure that we are living up to that responsibility.
Great. Dr. Kellett, why don't you comment?
I also feel very privileged to be on this panel, and that was a wonderful talk this morning. I everything they said, and the piece I would add to that is that medicine, I think everybody agrees, is essentially a moral practice in the sense that we are applied scientists. There's a great demand for knowledge and tolerance of ambiguity and uncertainty. It's a very demanding day-to-day practice. It's a very relational practice. It requires a commitment to lifelong learning and adaptability beyond anything. Particularly this last year has demonstrated how adaptable we are required to be in order to practice effectively. So I would just say the additional piece I would add here is that we are in a time, I believe, of crisis, a transition in our profession, where there's a kind of romantic notion that we're training physicians to care for patients one-on-one, but the challenges to that are very great because the healthcare systems are pressuring the nature of that relationship. And I think as Dr. Plouzogin pointed out this morning, we need to push back on that as a profession. That is our obligation. We're primarily obligated to our patients and their best needs. And so it's particularly important now, I think, to think about aspects of character. We'll talk more about which pieces of character we think are most important, but I think there's a adaptability, a courage, a virtuosity in that we need to prepare our future in the practice to hold dear the traditions of our practice, and to hold the systems accountable to that as well, and sort of be good citizens of both. So I think that would be my added piece.
Yeah. And I think coming out of this time too, I think one of the characteristics I've been looking at is flexibility. How can we be flexible and outspoken, but be flexible to make that happen? So Dr. Harris, can you talk a bit about what character traits or virtues have been most important in your life and career? And maybe you all could add a little bit. Has that changed over the last year and a half when you look about what you may have to develop in the future or accentuate?
Well, let me start with the second part of that. So certainly those virtues or character traits have not changed, but I can tell you that I've become more passionate and perhaps, if I'm very honest, a little bit less patient about the work that needs to be done. A lot of folks, and I talked about this even before the COVID at the beginning of my presidential year, because there was an urgency of the moment around a lot of things, right? But certainly I've become a little less patient about what I guess at vocalizing. I definitely believe that this virus, I already appreciated humility, right? And this virus has certainly, I think, elevated that appreciation, because whenever we think we have something about this virus known, it changes and teaches us something else. So the character traits that I think I brought in to pre-COVID and actually brought into medicine, and I'll have to say my personal story a bit. I went to medical school late, right? Maybe not late, but later on. So I didn't go straight through. I was 28. And I think I brought some of that age and experience and wisdom to medical school. I remember for me, and I can just speak for me, I had no problem saying I didn't know something, because I worried about killing someone by pretending to know something that I didn't know. So I think I brought that in, and I probably brought that into undergraduate because I think my family taught me that. So it's humility, I think, is critical. The other issue, and someone talked about flexibility, is critical. And the other issue for me is integrity. I always say when I'm making difficult decisions, when I'm hopefully 90 or 100 and I'm just on the front porch thinking about life, I always say, what will I want to have learned about that particular decision? And so, not a lot else may be important. So I think it's integrity, it's humility, it's being self-aware, which I think that actually, as a psychiatrist, I probably learned during my psychiatric training, but we have to be very aware, that a trait that I believe is important as physicians, be very aware of our own issues. This is coming up as we talk about health inequities and as we talk about structural racism and our own implicit biases. Of course, that's a whole different conversation, but in order to move forward on those, we have to look inward. And I think those are critical traits.
That's important. When I went to med school, I was 21, so I was one of those, but my class average age was 28. And I will tell you, those that had done something else really helped those of us who hadn't to be able to say, I don't know, or to be comfortable when in a group setting. Dr. Curling, you want to talk a bit about your virtues and character traits that you feel are most important?
Well, I think Aristotle would tell us that the best judge of our own character is other virtuous people. So I'm hesitant to identify what virtues I may have. But it seems to me, looking at others, the virtue that has proven to me to be the most critical one for good physicians, for good practice of medicine, is a dogged, insistent, relentless moral commitment, if you will, a kind of commitment to the patients and particularly to their health. I think the greatest temptation of our time and the most pervasive vice that undermines good medicine and the possibility of virtuous physicians is a moral detachment, a kind of treating medicine as something that one withdraws from personally, that is a professional area, and you have your personal domain you keep separate. So that relentless commitment to the patient's health, I think, is the critical virtue for good physicians.
I look at it as a pact. As you know, I'm a surgeon, so it's that pact you make with that patient that you'll forever be true. Dr. Kellett, you want to comment on the thoughts of most important? We agree with all the ones said.
I agree with all of that. And I guess I would add, so my personal story is that I'm the daughter of a refugee and a Holocaust survivor. Was raised among people who had, that terrible and awful experience, but also that post-traumatic resilience that was so inspiring. I was clearly inspired to, I'm not sure how much choice I had about my career path, but I was inspired to do it in a way that was courage and judgment first. There was a kind of I would like to say I've learned humility now in my current position in leading the current institute and having the privilege of being able to influence the educational system for our profession. I feel quite clear that it's integrity, humility that's important. But early on, it was fierceness, it was courage. It was a sense that it is a moral profession and that we have a role well beyond the particulars of the practice in the moment. So I think those are the pieces I would add to everything the rest of you have said.
Thank you. And Dr. Curlin sort of mentioned a bit about vices or those things that are dangerous or tempting. You want to comment on that, Dr. Khaled, about when you look at all your teaching and things you do with virtues, where do we go astray?
I think my biggest frustration with us, I would say with those of us who have taken on the mantle of educating the next generation of physicians, is a commitment in a blanket way to a set of traditions that we should probably be a little bit more vigorous around questioning, not the core fundamental values and virtues, but about the practices. And that's where I think we've gone astray. I think people have, we can talk in more detail about how to better educate future physicians, but I think we're in particularly challenging times. I think our students are watching us. I think we have to be very, very clear. I think, as everybody has said, we will need to live our own values and virtues very explicitly. This generation is watching very carefully, and that's where we could go astray, or we could be fantastic.
And actually, many of them are our kids, right? We raise them to be like that, right, as they come up. And as you, in your role as the president of the AMA, Dr. Harris, I can't imagine what things you saw and did when you are a leader. It is amazing the unusual behaviors of many you see. Can you comment on vices that are most dangerous or tempting, or things that you worry about in our profession as we go forward?
Well, I'm going to comment on that, but I do want to follow up on, first of all, the students and the young trainees. They do, I think, keep us honest, and that is a good thing. Although I always point out that we should always be open to intergenerational learning, right? So I would say that no one generation has all the answers. And so I think that is a worry. If you think that your way and the way you are thinking about things is the absolute right way to think about it. And so I think, there's wisdom and there's a vice in just deciding that, either my generation got it right, my specialty got it right, and yours gets it wrong. And so that either or, that zero sum game thinking. But I do think the younger trainees, the medical students, like particularly around the AMA, I am always impressed. And I think they call out and call in. And I think about that too. And you heard me say my impatience. And there are some folks that I am calling out, unabashedly calling out. And this is both within medicine and with the larger issues. And there are other folks that I want to call in, which means I'm pointing out issues, and I'm saying, let's have a conversation. But I do, and this is what's changed for me, I do require folks to come to the conversation with some knowledge. So I think we should require that as we think about educating the next generation of physicians. We should require that as we talk about equity and health disparities. We should require that as we talk about policy, that folks come to the conversation with some knowledge. I do also want to say, and some of you may know, the AMA sort of took this on about 8 years ago. With our program, it's called officially Accelerating Change in Medical Education, but we gave, $11 $1 million grants. Not that medical schools were not already innovating, but we wanted to sort of elevate it and amplify, and that's been so amazing. And then we saw that, okay, we're sort of teaching the medical students, but what about, the next level, graduate medical education? But the bigger issue is the system, right? So after you go out into the world, we know that our systems are not always have not always progressed as far. And I think we have to think about that. And of course, that is one reason I think I've had the privilege of again being in organized medicine, because we can think about those big systems and what they need to change. Because if we just sort of, it's not either or, it's both and. We do need to educate ourselves. We need to teach the young folks, but we also need to make sure that the systems, the external systems, those most often misaligned disincentives need to change. And we have to advocate in that arena.
I agree. So, Dr. Kurland, can you talk a bit about the primary influences in the development of your own character when you think back to it? Where did those influences come from?
Sure. I think I was thinking about this a little bit, and I think on the surface level, the most obvious answers have been my family, my parents, my grandparents, and my 6 siblings have deeply formed me from infancy through countless conversations and interactions, and forcing me to develop habits that I didn't want, but then I come to see and appreciate. Then I think friendships, particularly for me, starting in college, and then beyond that, friendships in which I have learned things that I struggled to learn in my family of origin, including for me how to rest and how to play, and how to take myself less seriously. And then, of course, in the practice of medicine, exemplars. I think particularly of a senior resident I had when I was an intern named Kraus, who was extraordinarily demanding of me, and who over the course of 2 months that I had him as my senior resident, taught me more and formed in me more the habits of being a good physician than I think anyone else ever did before or since. Then on a deeper level, just briefly, I have to say, as a Christian, I recognize that the predicament of becoming virtuous is not not abstract or just a question of kind of social science and management. It's a deep question of grappling with and overcoming the power of sin, and sin not as just little transgressions an individual might commit, but what Reinhold Niebuhr called the one Christian doctrine for which there is ample empirical evidence. This kind of tendency we all have toward being selfish, toward being focused on our own good at the exclusion of others, toward biases that are unjust, toward moral detachment, toward corruption in the pursuit of money, toward creating systems, as Dr. Harris said, that are themselves broken and corrupt us further. And so I think on the deeper level, that the grace that is, as Christians use the term, that is offered by God through all the kinds of means of grace, have probably been more formative in my life, and even in ways I'm not fully aware of, than anything else.
Thanks. How about you, Dr. Harris, your primary influences on the development of your character?
I think I have to agree. It was my family. I grew up in a small town in West Virginia, and but we had a very large extended family, 6 of my father's siblings, and my mother's family, and my grandmother's, both sets of grandparents lived within an hour's drive, one within 2-minute walk and the other an hour's drive. And so, we were a very close-knit family. And I pulled so much from all of the different members of my family. For instance, I recall my grandmother, and she used, a little bit more spicy language, but from my paternal grandmother, but from her, I learned self-worth and self-value. She taught me that early on. And by the way, I want everyone to know this, and the other panelists may also note this. There's not a straight line, and there's not an on-off switch. And I will just speak for myself, am still on my journey. There are some days and some instances when I'm clear about this, and it comes out in others when I doubt, and we, the imposter syndrome and that people have talked about. So I don't want folks to know that, I'm there. I believe that I am still on my journey of learning all the lessons from my paternal grandmother. My maternal, grandmother, I think, taught me that to care for others, and compassion is critical, and giving of yourself. And of course, my father taught me that, and my mother taught me to fight for things that I believe in. And so again, the compilation of family members and friends. Also, my sorority, I'll have to mention, and people don't normally think that, and people have heard a lot more about sororities since the election of Vice President Kamala Harris. We share the same sorority, and actually, I believe that the Black sororities were formed out of a mission from being excluded and some other broader issues, social justice, and so I learned so much in my undergraduate years from my sorority. So I would say, and I learn every day from every experience. I corrected myself earlier. I used to say I went to medical school late, but late is a judgment call. I went to medical school later in life, and now I'm able to appreciate more so than then all of the detours and the setbacks that I've, experienced over my career, and appreciated them as learning moments. And so I believe every setback, every detour, every lesson learned from family and friends have shaped who I am today. The whole experience at the AMA, running for office, and getting to know folks and the details of what's going on in our profession from a broad perspective, that helped me as well.
I know when those doors shut, you as a surgeon, we were sort of taught to beat them down, but you really should go through that other door, and you don't want to go through a window. You can hurt yourself. So you want to go, and all those doors that closed got you to that new spot. Dr. Callett, you mentioned a bit about your family in your previous discussion. Certainly very powerful background with your family during the Holocaust. Can you talk more about primary influences on development of your character?
Yeah, I also what they said, family, particularly my parents. My mother was a refugee. My father was born in the United States to immigrants. So that, and we had a very small family and a lot of ghosts, right? So there was this very extended family who just weren't physically there, but there was a faith community. There was a larger community. I actually would like to emphasize my education in this New York City public schools, where I had a fourth grade teacher who recognized that despite the fact that I wasn't reading up to grade level, that I was smart. And I can still remember his just making a commitment, just saying that. Actually, he probably did much more, but investing as an educator. I went to the City College of New York to what was then almost a brand new BSMD program. It was a 6-year program, the Sophie Davis School for Biomedical Education, where I met some of the greats of community medicine, and H. Jack Geiger, and other folks that I could not have appreciated at the time were so stunningly good role models for what would be a career in medicine. I signed a contract when I entered my undergraduate as a freshman in college to serve the underserved in New York City in exchange for a relatively inexpensive medical education. And then I just want to tell a quick story, which is my very first day of internship. I was an internal medicine intern, and I was called to the emergency room to see my first patient, who I was told was a young woman in diabetic ketoacidosis. And on my way to the emergency room, I was like rehearsing in my mind everything I knew about DKA, and I was, the potassium and IV fluids and insulin, and I hope she's breathing, she's not intubated. And I walk into the emergency room, and the scene was of what looks like an ICU, and a very petite, blonde, blue-eyed, what looked like a child to me, standing in the middle of this ICU setting, screaming bloody murder and cursing like a sailor. And there were hospital police surrounding her. She was within 10 or 15 feet. This was my patient. And the director of the emergency room, who had known me because I had done an elective with him, stood right behind me, put his hand on my shoulder, And he said, Adina, this one's for you. I will be there to help you. And then she streaked in front of me and locked herself in the bathroom. This was a young woman with a blood pH around 7. For those of you who know what that means, she should not have been conscious. And then I had to sit on the floor and talk her out of the bathroom. That moment where I knew behind me stood my mentor, a man who, Louis Goldfrank, who is the father of emergency medicine. So, but a moral figure who said, this is going to be hard. It's not going to be hard in the ways you were thinking. And I am there. I see you. I believe in you. I've had a handful, not many, but a handful of those kinds of experiences that have been very influential on my career and in understanding the complex, what my job is in this situation. And it really, and by the way, she was my patient for the 3 years of medicine residency. It taught me everything I need to know about DKA and how to take care of very complex. The adolescent psychiatrist refused to take care of her. She was 17, but she was emancipated, so she went to the adult service for a number of reasons. And the complexities of that one case taught me, that one young woman taught me so much. So my mentors, my patients, and of course my family and my community.
So you named one of your role models, a more recent role model or another one to make that happen, or too many to count?
So many, so many now in my work with the Kern Institute. I've met so many people outside of our profession who have so much to offer in ways of thinking about. I'll name one. There's a moral psychologist whose name is Mickey Bebow, whose work was influential on my work in medical professional identity formation. She didn't work in medicine; she worked in dentistry. But her clarity, and she's a woman in her 80s now, but very much also was there, standing behind me, her hand on my shoulder, saying, "You can do this. We can understand medical professional identity formation in your profession. I will help you." And she's still doing that work, so as is Dr. Goldfrank and others.
Dr. Harris, how about your role models?
And I just wanted to add, because I think it's important, all of us are telling these stories, and I think that's so important, because sometimes we sort of look for those big learning moments, right? But really it's probably a combination of all of those, tiny learning moments that unless we wrote them down, every second, every day, we would miss them. And so I was thinking about a couple of stories. And one story is my aunt, again, my issue of going back to medical school later, had I missed the opportunity. And I remember some folks were saying, "You're going to be so old." Now, of course, old was relative. Remember, this was quite a while ago, but you're going to be so old when you finish. And I was thinking, maybe that's right. Maybe I should, back to, not always being confident in who I am. And I remember my aunt said, "Well, you're going to be," I think somebody said, "You're going to be 40 or whatever they said when you finish residency." And my aunt said, "You're going to be 40 anyway. So you might as well be 40 and a doctor." So that was, and I just, that was just the story. And that I said, that's right. And that just cemented I'm going for this. And it is not too late. And again, all the experiences I had before then. And I was also thinking about, our interactions with patients and even how certain experiences forever change us. And I remember for me too, and I'll tell them quickly. One was a woman who came in. She was having some respiratory difficulties, which progressed pretty quickly. And so she had to be intubated. And I went to the ICU to see her. And she, of course, could not speak. So she wrote on a pad. She said, "Am I going to be okay?" And, of course, I was a third-year medical student, but not from what I heard. The resident said, "We're going to, put her on the ventilator and give her lungs a chance to heal, and she'll likely be fine," is what, And I came back the next day and she was deceased. And it took me a while, and I was thinking of the lecture this morning, to figure out that I told her she was going to be fine. And that was one of those moments. And I sort of worked through that myself, right? And so, and again, going older, I was able to work through that. And one more experience I had that I worked through, I remember third year, we were on every fourth night back then. And by the way, no judgment on that, because I really do believe that we need to monitor those hours and figure out that. But I also know that I learned a lot sort of following a patient for, 36 hours or so. So we can still have fair-minded debates and conversations, but it's 3 a.m. and I've admitted my, I think, 16th patient, and it was someone who had COPD and on oxygen, and they were smoking. And I remember, again, in the middle of the night, I was frustrated with that patient. And I said, you know what? You're smoking. And I was, and no, I didn't, not with him, just in my own mind, sort of, being frustrated with the patient. But I easily self-corrected and said, let me know this patient's story. Why are they still smoking and they have COPD? And so I think that goes to today as we think about understanding the stories. We need to get back to, or we need to include, I will say, the narrative. We oftentimes write patient non-compliant with medication, and we end there, right? That's the beginning, but why are they non-compliant? Can they not afford it? Are they deciding between rent and medication? Did they have to give money, their grandparent, to their grandchildren to get something, to go to college even? So I think as we, think through and figure out how we educate the next generation, I'm so heartened to see, what UVA is doing and other schools. We have to figure that out, but then we have to make sure that the systems learn that as well.
Great. Thank you. Dr. Curlin, your role model.
I'll mention two. We recently lost James Bryan, who was a long-standing professor of medicine, internal medicine at the University of North Carolina, and still stands to me as probably the most beautiful picture of a good physician that I personally have had the privilege of observing. I rounded with him for just a few days on a third-year clerkship. I'd heard that he was extraordinary, and I can't describe it better than to say it was to be captured by the beauty of a brilliant physician, good physician, virtuous physician about his work. And that included both a kind of magisterial understanding of the science applied with practical wisdom, what physicians have called clinical judgment, to that case, and an uncanny dialed in attention to his patients and a delight in them. The second one is the person I mentioned briefly earlier, Kraus, who is a more irascible, eclectic, idiosyncratic personality than Dr. Bryan. But he demanded of me and of other people that worked under him the highest level of commitment, showing up early, and never, he had this kind of ability to obviously acknowledge our failings, but he was not going to allow us to accept failure to help a patient get better unless it was after our very best efforts. And there's something I saw in Carl I wanted to mention here, which is we would walk the halls at the University of Chicago, and Carl Kraus knew the name of every single person who worked in that hospital and would speak to them as he went down. Susie, Bob, Tim, from the lowest orderly to the highest administrator. And he kind of treated them in a way that, best I could tell, that was equal in terms of appreciation for who they were and not over appreciating who they are in terms of the folks who had high positions. And I saw that evoke in everyone, in ways that were otherwise unmatched, a mutual effort to do what was necessary to preserve and restore a particular patient's health, even over obstacles, that, again, captivated me. And so those two images have lived on as moral exemplars, kind of inspiring me ever since.
Yeah, I really apologize. My house has exploded right now with the dog barking and the phone ringing, and I just don't even know what to say. I guess I'm going to show you incredible flexibility. So let's move on then to how character can be educated or improved among current doctors. Why don't you start, Dr. Curlin?
Well, I mean, I think the thing that I could contribute most here is to constructively, I hope, rain on our parade a little bit, and say briefly why I'm skeptical that the current interest in character formation and virtue formation in medical education will change the things that it's seeking to respond to, and why it might even make them worse. And that's because if I'll recur here to the writings of Alasdair MacIntyre, who probably more than anyone else has intellectually contributed to the recovery of attention to the virtues in the last generation. And in the beginning of his book, After Virtue, he starts with a little 3-page first chapter, and I encourage everybody who hasn't read it to look at it. You can find it online, what he calls a disquieting suggestion. And the bottom line in this disquieting suggestion is he says he thinks we're living in something like, with respect to the moral life, in something like what we'd be living in if all of modern science were destroyed by some kind of terrible event. And then a generation later, people they're finding artifacts and trying to restore science. So he suggests that what we're doing now in the moral life is we're kind of pulling at ideas, virtues, character, professionalism, humility, justice, equality, and so on, but in a way that's detached from the moral traditions, the substantive ways of life in which those terms have content and meaning and direction. And I worry that that's what's going on in medicine. In this, let me try to distill it in this way, that we have right now, we do not have what MacIntyre says we must have to actually have a coherent practice. And that is a clear recognition of the internal goods of medicine, that thing which we are all after and we can agree about, and it's concrete and objective and real, that helps us know when you have a good physician and a bad physician, when humility is the right response versus impatience is the right response. Traditionally, that was understood to be the health of the patient as this objective bodily norm. But increasingly in our culture, we are all kind of allergic to suggesting that we know what a patient's good is. And I think that's emphasized even this morning by the language of open-mindedness and not being too sure and so on. But if we aren't sure what we're after as physicians, then I don't see how we're going to train people to be good at achieving it. And I worry that that's the state we're in. And so we're pulling at these ideas of character, but just like people for now 2 generations have pulled at problems of lack of professionalism and problems of needing a biopsychosocial spiritual model and problems of reductionism and problems of not being patient-centered and problems of not having shared decision-making. And we just keep coming up with new language to deal with this vacuum, which I think is a real spiritual moral vacuum of not having a pattern, not having even clarity among ourselves about what it is we're after, and instead kind of defaulting always to well-being as the patient perceives it. And we're just providers of services who want to be compassionate as we provide. And I think that ultimately won't work.
So how do we go forward then, Dr. Khaled, with this to educate, improve this, with a lot of noise going on, as Dr. Curlin points out?
Yeah, I agree and disagree. I'm glad that you threw down the gauntlet, because I do, in many ways, agree that we are in a sea of ideas that don't make that much sense as a pragmatic matter. I think there's a couple of things. One is we must think about the ultimate goal of medical education. My domain is medical education, that we must think about why we are educating physicians and keep that front and center. So for instance, in the Curran Institute, our mission is to ensure that the society, that patients get the physicians they deserve, to improve a number of, a long list of potential outcomes, only some of which are around well-being and the perception that people have of liking or disliking the outcome. Because we are a scientific field, and we have many outcomes we could measure, but we have to keep reminding ourselves that the purpose of medical education is the care of the patient and not the outcome of medical education, meaning education, intermediate outcomes, educational outcomes. The second thing I would say is that we must think about the development of the individuals becoming physicians as a developmental process, not as an absolute. It is a ongoing formation of an identity that must be internalized for the purposes of being able to manage the complexity, right? That's why you have to internalize a strong identity as a physician, because otherwise you would be flapping in the wind, right? You need a strong sense of right and wrong, a strong sense of good and bad in order to manage the complexity. And I think we know a lot about that, and we can do that. And I think a lot of what Dr. Pluzogan presented is similar to what my thoughts are. The third thing I'm going to say, I'm going to throw the gauntlet down and say, I don't care, and I put this in air quotes, how we teach them. I really don't care. There's many good ways. We might as well do it in good ways. I care what they learn. And I, therefore, if given my druthers, and I'll say this, and I know this is being taped, so it'll be in perpetuity. I think we need to be very clear about what the outcomes of our various training programs need to be. We need to get very good at assessing those outcomes. And we need to engage with our trainees about co-creating the curriculum along the way. They are adults. I know, Dr. Harris, you think 26 is old, but so I don't see that as terribly old. I wish more of our students actually would wait. As others have said, the more mature, the better, I would say, and age being only one predictor of maturity, that we need to engage our trainees in a journey toward becoming professionals, and how they get there. I think they're really smart about learning. They are the Ferraris of learners. They can figure it out. We can provide them with resources, but we need to be clear, I think, in the leadership, wearing the leadership hat, what that looks like. And I think we're getting there, and it looks very bureaucratic right now around competencies and details. And I think that's gonna, that'll keep evolving, but we need to be clear. We need to tell them where you need to be, how you need to demonstrate to us, the various ways you need to demonstrate to us that you've gotten there. And then you and I together, student and learner, student and teacher, and that relationship is the relationship within which you need to learn to become a physician. And again, I'm agnostic to the instructional design. There's many good ways. Medical schools are experimenting with all sorts of things. But I have to agree with Dr. Curlin that many of these ideas are distracting rather than helpful in determining those sort of the ultimate vision. However, we do need to have a vision, and I'm not sure we have a consensus on what that looks like. And so that's the hard work I think we should be doing. And all these words, character traits and virtues, and they're all in there. They're all critical, but I would like to see us have that conversation, I think.
Dr. Harris, why don't you comment? Can we ever get to consensus? Because each school is different. I've been at multiple medical institutions that we go forward, and each kid is different, right? So if you look at age, their background, and we're really pushing hard to even have more diverse students to get into medical school, because that's the right thing to do. How can we get them along their journey? Your thoughts?
Yes, and I think there are areas of agreement and areas of disagreement. We are in a sea of ideas, and I'm not sure we can get to consensus. And then my issue is, do we have to right now? Because I think that on this issue and many others, we spend a lot of time debating, right? And that's the energy, is the debate, instead of, and we could debate from now until the end of time, and we probably won't have it right, and we probably won't get to consensus. And so I think what we should do is, and yes, medical schools are innovating and trying. We heard some things this morning. Let's do some things. Let's do some things that are evidence-based, right? I'm not saying just somebody have a good idea, but let's do some things with some evidence. And let's apply some scientific rigor, because for so often we don't do what I call inspect what we expect. And even if it's a shorter term expectation, we don't inspect that until 5 years down the road, and we figure out, well, this is not getting us to where we at least want to be. So I do hope that we spend less time we should all go forward, or perhaps even at the school, go forward with a shared definition, right? We may not get all of the schools for a shared definition. So we should go forward with a shared definition, and then do the work, inspect what we expect, and stop having these esoteric, abstract debates. We should have those, but as long as they don't get in the way of doing something. And I will say about the age, and again, I agree. And now, of course, 26 is not old, but if I were Queen of the United States, I would have everyone do at least a year of service. I think it is ridiculous to ask 18-year-olds to decide what they want to do for the rest of their lives. That's just my editorial comment today. But I know we don't have a system wrapped around the ability to do that, but that's what I would do, because the more mature, first of all, you're able to then make decisions. I worry about our young folks making a decision, especially, and I'll just say this, as we think about burnout, and as we think about medical student and physician suicide. You get to the end of medical school, you have $200,000 in debt, and you realize it's not for you. So I think we need to, that's a subset of a conversation, but that brings up broader issues. But those are all the conversations we should be having.
Any follow-up, Dr. Curlin?
Yeah, briefly, I agree that the service is a good idea. That can be deeply formative in practicing selflessness and practicing humility. I bet here's a challenge. So the question is, how, if our learners are to be, and this is to Adina's point, if they're to be kind of co-deciding with us what they're aiming for, I think we have to recognize that that's very odd in the tradition of apprenticeship, and I think that it's a problem that gets to that root problem of us having this moral kind of agnosticism about what medicine is for. And any agreed shared definition I propose that we could come up with across, say, the AAMC or across medical schools will inevitably be pretty anodyne and pretty vacuous, because there are real disagreements that we can't settle. Things about, like, take something obvious. Should doctors ever participate in intentionally hastening their patient's death? If you can't solve that question, you can't solve a critical fundamental disagreement that shapes what you think you're talking about when you talk about justice, and when you talk about integrity, and you talk about fulfilling your profession. So there's a practice across the medical schools now of having medical students, many schools do this, write their own Hippocratic oath. I think that's a symptom of a deep moral problem. You would never imagine a soldier showing up to basic training and saying, I'm going to write out what I think it is to be a soldier. I'm going to negotiate with my people who are going to train me what it is to be a soldier. And the reason is we think there's something serious to being a soldier, or a clergy member for that matter. And I think there should be similarly with medicine. And the fact that we are open-minded about tend to emphasize open-mindedness to such an extent, I think communicates to our students that there's nothing substantively seriously at stake in this work. And that, I think, is a disservice to them. I teach students every year in medical ethics, and I'm struck that the consistent witness from them is they are never in their medical training being asked to grapple with the question, what is medicine for? Mm-hmm. They are never being asked to really grapple with the question how a particular practice is good or not good in relation to what medicine is for. And as a result, they are taught to default to this kind of vague notion of well-being and outcomes and, et cetera, being professional, being compassionate. And they just start to morally detach, and they just do what the system kind of forms them to do. And if you have a corrupt system, as we've all can agree about, you just, everything stays, all the powers stay in place, and we just keep talking in different ways, but the same dynamics keep going forward.
Dr. Callett, why don't you follow up, and then we'll move on to another question.
I just want to say that I did not say that students will co-create the outcomes. I said students would co-create the learning experience. They would be responsible for their own learning because that's what they are expert at, how they best learn, and we have to guide them. But I don't think sitting in lecture halls or in highly structured curricula is the best way to take adult learners and get them to those very, very high standards that we have for them. So just to be clear.
Thank you.
And I knew Dr. Bryant. I was at UNC for a couple of years as a fellow, and I rounded on one of his patients once, was an elderly African-American man with a very thick North Carolina accent. And he said, "If it wasn't for God and Dr. Bryant, I wouldn't be alive." And that sticks in my head. That was a long time ago. That sticks in my head. And I have multiple feelings about the association of Dr. Bryant and God. And the students I made rounds with, who I was a fellow, so I was just a little bit older than they were. That, while that's very moving, I have complicated feelings about that model of medicine. And I've spent much of my career trying to hold those role models and the other role models that of the students coming up that cannot do that. They do not have the affordances to be that kind of exemplar. They don't look right. They don't have as deep a voice. They don't have the same gray hair. So those are the kinds of conversations. I agree with Patrice that I want to have those conversations. I don't think we're going to come to consensus on how we train medical students. I think every school has a particular vision for its own, but there is something about being a physician that is the same all over the world. So I've traveled a lot and I've seen medical schools all over, and there's something very core. I think we could articulate that. We have articulated that. It's not that it's unarticulated, but we might want to have those conversations more explicitly and less in the weeds about what are the competencies and what, although those things are the pragmatic day-to-day, right? We do go back to our medical schools and we teach in the courses and we round, with the clerks, and it still takes 4 years in most places. And we really don't know why, but that's what it takes. So those are the kinds of things I think I want to engage students in that. I want to engage the future of our profession in those conversations. And that would, I think, be the curricular piece that doesn't exist at the moment. And in many places, it does exist in certain places, but in general.
So why don't we change gears just a little bit and let's talk about the lack of social trust. We've seen that with the virus. We've seen that when I trained with HIV, that we've seen lots of issues with social trust. What can doctors do? What can doctors do to promote social trust? Why don't we start off with you, Dr. Harris?
Can you hear me? Okay, great. And if I wanted to add one on the last point, I think the conversation is the thing, right? That is the learning moment. We've got to get to, so improve patient outcomes, but we've got to get to the learning moment. The conversation is the thing. So I would say, Dr. Curlin, I would think about the Hippocratic Oath. The conversation is the thing. You raised the points. Okay, Dewey, is it the Hippocratic Oath? Students are writing their own. And so the conversation, why are students writing their own? What is it about the traditional, the original Hippocratic Oath that some students didn't feel represented who they are or their own ideals? And so while, I agree that I'm sure there could be some Hippocratic Oath that didn't even meet the, foundational principles of what we want, I think most people might think, well, Hippocrates is the father of medicine. Maybe, Imhotep from Africa was the father of medicine. So it doesn't feel good to me as an African American. I recited the traditional Hippocratic Oath, but so I think those are some of the conversations that students are having. And so I think we have to allow that and understand that. And of course, it can't be, medicine is a fun thing or some ridiculous notion that's outside the bounds, but allowing folks to connect to it deeply and writing their own might help with that might be a piece of the issue. And so what can we do? What can medicine do? And I think, coming, of course, and being a leader at the AMA, the foundation of what we do is a code of medical ethics. And I can tell you that I had the wonderful privilege of being the board liaison to CJA, the Council on Ethical and Judicial Affairs. And I learned so much more than I didn't know. And the president-elect of the AMA gets to appoint one member. And so you feel and you're connected to that. And so I think we continue to fall back on the very core issues of the Code of Medical Ethics. There was a debate, and I'll put that in quotes. It wasn't a debate to me, but there was a debate about whether or not physicians should even be talking about equity and racism and police brutality, which we did this last year at the AMA. And I would say, it relates to health. So that would be the argument that I would make. Now, we should not opine on everything, but if there is an intersection with health, in my opinion, there's an opportunity there. So I think that as physicians, we continue to, fall back from an organizational level on that code. We can continue to educate ourselves. We can continue to ask the questions and have these fair-minded debates, these conversations that you propose. And I'm not proposing we get to an answer or there's a right or wrong answer, but we have these conversations. So I think that's what we can do as physicians. I think that it's what we can do as organizations. And as organizations, we can push back on those systemic issues that prevent us from practicing medicine in the way that we think is in the best interest of our patients. So those are just a few of the things that I think we can do.
Yeah, Dr. Callett, you want to talk about how to improve social trust? What can doctors do?
Well, I think COVID has handed us quite the opportunity. I think that after decades of diminishing trust in the profession, physicians and other health professionals, our other colleagues, are now all of a sudden back on the pedestal in many ways, which is a dangerous place to be. But we have an opportunity, and I know a number of people are writing about this, and I believe we need to renegotiate our social contract to the extent that we have a contract at all. And I understand that that's a metaphor more than a physical fact. But there's a few things about the way that the logic of markets, the commodification and productivity language of the healthcare environment is very, very toxic to the development of the profession and the professional, but also fundamentally for the patients, for the care of patients. And I think it's obscuring, that language is obscuring some really very, very difficult things about the healthcare system, like its expense and while many of my colleagues are deeply involved in quality and safety, and clearly quality and safety is front forward, there's a loss. I think we've had a loss of the language of the importance of those relationships over time that lead to health. And there's tons of evidence for that. So so that's one thing I while in medical school curricula and residency curricula, we now have to talk obviously about systems, and that's very, very important to make sure that our future physicians are good citizens of the system. I think they also need to be critical citizens and engage in those conversations. I think those debates, those conversations, and I don't see enough of that yet. Part of that is power. Part of it is that our residency programs live in the systems, and our medical schools are increasingly intertwined with the systems, as you know, as Dean and CEO. The other thing, I have a little bit of a rant that I just want to share, which is that there's now a definition of physician practice that has more to do with location and time of day than it does with clinical wisdom or with that practical wisdom. It really irritates the hospitalists versus ambulatorists, dayalists and nightalists. I understand that those are descriptors of the jobs that physicians can have in systems, but I really would like to have a really robust conversation in the profession about how we are being defined by the logic of markets and the with all the upsides and downsides. And I want to engage our trainees in that so that they understand the distinction between the work of being a physician and the job of being a physician at any one time in a person's life. And then I want to talk to physicians, old and young, about careers in medicine, because I think it is a profession. I think as Far pointed out earlier, one of the ancient professions, where we have the most experience, among many healthcare professionals and the health professions. The thing we have that's different from our colleagues, from the other health professionals on the team, is that we are an ancient profession. And we do have a long-standing tradition of this and a deep intellectual tradition. And I think we need to lead forward with that within the systems.
Thank you. And Dr. Curlin, talk about social trust. I know I have a list of things now of what COVID-19 has done for me lately, and it's not a long list, but it has actually allowed me to go forward and talk about many things that a year ago as CEO and dean, perhaps I wouldn't have spoken about social trust and opportunities to say things that are more realistically important. Your thoughts on that?
Yes, here are my thoughts. I think COVID has reminded both professions, practitioners of medicine and the public of what it is that the public reasonably values in the profession, namely that it can count on a group of people who have disciplined themselves and committed themselves in even a sacred way to showing up when people's health is diminished or threatened, and doing their level best with all the resources available to them to preserve and restore those people's health, notwithstanding and without respect to any other patient characteristics that are irrelevant to their health. Race, class, politics, obviously that's been in our forefront this year. If you're sick, we have an obligation to you, which we are determined to fulfill. I think at its best, we've seen that this year, and that is what evokes in the public a kind of reminder. Oh yeah, that's why we've honored practitioners of medicine. And yet, as Adina points out, there's market. The market is enormously powerful. The market way of thinking fits the provision of healthcare services, which is the dominant language in medicine today. We are providers of what? Healthcare services. Toward what end? Well-being. What do we mean by that? Well, it depends. We don't want to be too sure. We got to be open-minded, et cetera. And I think that's gets back to that root challenge. How do we evoke social trust? We do what we've seen at its best in this year. We act in trustworthy ways. We reliably, with a commitment to the patient's good, particularly as that good involves health, show up, attend, without respect to patient's other characteristics. And just a caution on that, because I think it's also come out this year. There's distrust in science. And to me, that distrust is often well explained. Not that the distrust itself is well grounded, but that people don't trust science is because this claim of what science says has been overstated often. And similarly, here's my caution about formation of medical students. I've seen over the past 20 years, many voices, Don Berwick is one, saying we need to train medical students to go to their legislatures, to be writing op-eds, to be experts in housing policy, to be experts in how to respond to the deep sins of the United States. And I use that word intentionally in terms of persistent racism over generations, over centuries, how to respond to problems economically and so on. I don't think we have good reason to believe that medical students are going to be exceptionally authoritative, have a reasonable authority of expertise in these areas. So I worry that we're setting people up to go beyond their reasonable area of expertise, and we're suggesting to them that it's not really good enough to be a good physician who cares for anyone who's sick, preserving and restoring their health. But that is the foundation of why people esteem the practice of medicine. That's the most uncontroversial idea of what our social contract is. So I want to communicate to students, that's good. If that's all you do, and if you're really kind of ignorant about how to write the right policy, that's okay if you're showing up and doing a good job of taking care of people when they're sick.
Right. Well, I think as a CEO,
Dr. Curlin, I have to, because I want to make sure, Dr. Curlin, and we could agree to disagree and respect a diversity of opinion and thought and the disconfirming opinion. But I do think you're right, Dr. Curlin. You don't have to do that if that's not who you want to be. But I think we should allow for those students and trainees who want to be involved in advocacy, because it is critical work. It's not for everyone. People get to choose, but for those who want to incorporate advocacy as part of their professional lives, and in my personal opinion, I believe that they should, and at the very least know who your elected leaders are, because you are an expert in what your patients are going through. So you don't have to write a bill or, write policy, but you can educate legislators in what you see every day, what we see every day as a physician. So my definition of advocacy is from the, knowing who your legislators are and sending them an email once a year to running for office. And I think physicians should do all of those. I thought I heard, and again, we could just agree to disagree, but if I heard you correctly, that you said that race was irrelevant to health. Again, respecting that, but, could not disagree more. Structural racism, and which leads to the structural determinants of health and the social determinants of health have so much to do with one's health, and is definitely related to why we have health inequities, hypertension, diabetes, COVID. And so I just have to go on the record, and we could actually maybe have a larger panel one day having that conversation.
Well, no, if I may, I want to clarify that is not what I intended to say.
Okay.
No, absolutely, race matters for health profoundly in mortal ways, as we see in COVID, and as I see all the time in my work. And absolutely, physicians have to be attentive to everything that bears on their patient's health. What I mean is your commitment as a physician to care for people. What is your profession? And I would argue you profess to show up and care for people without respect to what their race is, meaning you don't not care for someone because they have a race that's different from yours. That was the idea, that it's that central commitment that is the one I think we could all agree. I find in my work, no one disagrees with that idea. And I think that's an important substantive commitment. So, and I would agree with you, Dr. Harrison, the way you put it. It seems to me that the way physicians rightly respond to all these other things is either as something they do in their role as a citizen, because we're never less than citizens, and or insofar as they're doing it as part of their profession of medicine, it's in ways that cohere with and extend and are motivated by and don't undermine that central obligation to care for people who are sick.
Well, we just have a minute or two left. And my comment would be, as we are looking at expanding our system here, is a pluralistic look at what physicians can do. There are so many things that you can do. You can be that doctor at the bedside at your clinic all day long. You can work rural, you can work urban, you can legislate, you can be a researcher, you can be a scientist. I think looking at and appreciating every person that comes to our profession and what they would like to do. And I think that's the piece that I'm working on, is to appreciate everyone in my community and what they contribute. So real quickly, I'll give you one sentence to say, what's the advice you give to students interested in studying medicine? We'll start with you, Dr. Collette. You got one sentence to tell them.
Okay, 1 second. I would say do it for the right reasons.
Great. All right, Dr. Harris.
Be authentic to your true self.
Great. Dr. Curlin.
Taking care of the sick and seeking to preserve and restore their health is a worthy way to spend your life.
Absolutely. I really want to thank all three of you for energy, for emotion, for passion, because you're the reasons that I bet a few people in this audience of 124 may actually choose to be a physician. And I do appreciate everything all three of you done in your careers and as we go forward. I didn't think we would be able to talk for over an hour, but we sure did. And I want to thank you so very much. Here's to you, Michael Lamb, you're taking over.
I am. Thank you all. That was terrific. I loved your conversation. As Julie said, your energy, your lively and spirited debate, and also your different perspectives. All of you had different ways of looking at medicine, but you really shared an emphasis on core virtues of character: wisdom, humility, flexibility, integrity, courage, compassion, resilience, self-awareness, and of course, a moral commitment to the patient's health. So I'm just grateful for your your challenge to us and your inspiration for how medicine might itself be a moral practice. So thank you all very much for that. I also want to thank our sponsors again from this conference, the Lilly Endowment, the John Templeton Foundation, and the Kern Family Foundation for making this conference possible, and to all of you for being part of this morning session. I hope you'll join us again in about 30 minutes at 12 p.m. Eastern time for our next session on character and business. The link actually is different for that session. It's in the chat, so please look to the chat for that link. We'll hope to see you there at about 12 o'clock Eastern time. So thank you all very much.